Yeah. Mm-hmm.
What was it mostly about?
He talked a lot about some of the different like international research companies and things like that.
Okay.
So some of those things got over my head.
Yeah, yeah, okay. Uh-huh.
She may be in
Okay.
the other room. I better go find her. Because she was coming.
This is the right place.
Yeah, this is it. Here, let me move this chair. Text Tanya and see where she's at. She may have the next room.
Test, test, test. Good morning. I think I will start since we're running a little bit late. I'm Dr. Suter. I'm an assistant professor of pediatric neurology at Baylor and Texas Children's. And I will attempt to give you a brief overview of movement disorders in CDKL5 syndrome. And I will juxtapose the movement problems that are known about a little bit to Rett syndrome. And I'm not doing that so much to sort of give you two for the price of one, but there is really a very little known about movement disorders in CDKL5 syndrome. And since there is some overlap with Rett syndrome, this may be helpful to stimulate what to look for in the future. So my main goals are to determine which movement disorders are frequent in CDKL5 syndrome, when you encounter these movement disorders in your children, whom to talk to, and what are they likely going to do to help you and your kids with the movement disorders. So very briefly, obviously you're all aware CDKL5 syndrome is caused by a mutation in the CDKL5 gene, and there is some overlap in the phenotypic spectrum with Rett syndrome, maybe in part because the kinase activity of CDKL5 influences the MECP2 gene, the Rett gene, and vice versa. So CDKL5 syndrome is really characterized by the early onset seizures, severe global developmental delay, GI problems, a fact that males tend to be more severely affected, and then motor problems as well, in that almost all have hand stereotypies, there's abnormality of muscle tone, there's severe hypotonia in infancy, and bruxism is very commonly encountered as well. So what are features that really overlap with Rett syndrome? Certainly the head size, the development of head size over time, the loss of expressive communication, but then several of the motor features are parallel those of Rett syndrome. Very frequent hand stereotypies, poor to absent voluntary hand use, and an abnormal gait if the child is ambulatory are common in both disorders. Rett syndrome is very heavily based on motor features, the diagnosis of Rett syndrome. I will skip this slide. If you look at the criteria for diagnosis of Rett syndrome that have really been updated in 2010, you can see that there are main criteria, and then there are some supportive criteria. And the main criteria, 2 out of the 4 main criteria deal with motor problems. So Rett syndrome is a clinical diagnosis, and we don't yet have a clinical spectrum of phenotypes that we have defined for CDKL5 syndrome, but I would expect that if this happens in the future, that motor problems would feature prominently. So what are the most common movement problems that you encounter in CDKL5 syndrome as we know of yet? Hand stereotypies occur in almost all children with CDKL5 syndrome, 91%. Most patients demonstrate a combination of different hand stereotypies. The most frequent ones are hand mouthing and clapping, and this is disparate from Rett syndrome, where the hand washing, the phenotype is much more frequent. The hand stereotypies usually appear in the first year of life in CDKL5 syndrome and can occur later in Rett syndrome. What about other movement disorders? Dystonia, and we'll go over these different terms in the second part of my talk, is very prominent in Rett syndrome. Is it prominent in CDKL5? We do not yet know from the literature, but on an observational basis, I would say yes, dystonia is very frequent in CDKL5 syndrome. What about another big group of movement disorders, chorea? Chorea is common in another Rett-like disorder, namely FOXG1 syndrome, and much less common in Rett syndrome. So it would be interesting to know how common chorea features in CDKL5 syndrome. What about the famous Parkinsonian features? So girls with Rett syndrome progress not only from a state of very low tone at birth to a state of increased tone and spasticity over lifetime, tendentially, but they also develop Parkinsonian features. They become much more slow in their movements. Their gait becomes altered. They take very short, little steps. They become overall more rigid, and their facial expressions become much less varied, which has profound implications on communication with the parents. We do not, it seems there's at least one study out there in Rett syndrome that found it seems to have found some neuropathological basis to these Parkinsonian features, but not a lot is known about Parkinsonism in Rett and its underlying pathology as well. What about ambulation in CDKL5 syndrome? In Rett, when they studied a large sample of girls from the natural history study and analyzed all the individual features of Rett syndrome, they found that gait or ambulation paralleled actually the overall severity of the syndrome the closest. For CDKL5, it appears that gait is also a very important feature for the quarter to a third of individuals that are actually able to walk, in that you can sort of make a determination that if your child walks, it may be milder affected overall than those individuals who are not able to walk. And that is from a study from 2008 that you can really subdivide. Those who do not acquire gait usually have a more severe microcephaly, hand apraxia, poverty of eye gaze, hand use, the teeth grinding, the bruxism, whilst those who are able to walk tend to do better. What about movements and actually location of the mutation in CDKL5 syndrome? So again, in Rett, there is much more known in that some mutations in Rett syndrome tended to do better with respect to motor function, gait, hand use, independent sitting, onset of stereotypies. And this is just a list of the mutations, not important for you here right now. But importantly, even in Rett, we do not understand why these specific mutations tended to lead to a milder motor phenotype. Do we have any such evidence for CDKL5 syndrome that specific mutations go hand in hand with better or worse motor function? In the closest that I could learn about myself is the Australian study based on the international CDKL5 database, where they were able to chisel out a relation between the location of the mutation in the gene and the onset of various acquirement of various milestones. For instance, the proportion of females who attained independent walking is plotted here, and you can see over age, if you, for instance, follow those with truncations after position 781, it seems that a bigger proportion, listed on the y-axis, achieves ambulation than earlier mutations. But this is still a work in progress as well. So there may be some correlation to actual location of the mutation. So, as you can see, there is not a great wealth of data out there of what, at least published data, of what movement disorders do we encounter in your children. And I want to now come to the second part of my talk, where I talk a little bit about the terms of these movement disorders that I've mentioned that we know about. Okay? So the first term that I used was dystonia. And what is dystonia really? It's an alteration in muscle tone, sort of producing a stiffness, a rigidity, in a fashion that produces spasms, and these spasms can be prolonged. The dystonia occurs when both an actor muscle, or a group of acting muscle, let's say, and antagonist muscles contract at the same time and sort of freeze a limb, facial muscles, you name it, for a while. These events are often prolonged, occasionally are brief and jerk-like and can then be confused with spasms, and they often lead to unnatural appearing body positions. If they're really intense, they can lead to a tremor, and then you can imagine, for instance, and maybe even have seen it in your children, that picture becomes very close to the picture that could be produced by a seizure. You have an extremity that is held and trembles, and it is very difficult to, simply by looking at that individual body part, to discern between seizures and dystonia in that condition. In the extreme, dystonia can also be painful. It is very important to realize that dystonia can really occur with many medical conditions and can have multiple underlying causes. So typically one needs many treatment approaches to treat dystonia. There is not a one-stop shop, one medication, one physical intervention that will be able to treat dystonia. These are just examples of dystonic positions. For instance, here is depicted here is blepharospasm, a sort of crunching up of the face around the eyes. This person could not open his eyes and eyelids at that point in time. Cervical dystonia is very frequent. I have encountered it in CDKL5, which leads to abnormal postures of the head. Certainly limb dystonia at the feet and ankles, maybe even the leg, where the feet are held for a while in abnormal positions, is very, very frequent. I'm not sure whether we'll be able to do this, but to give you an example of orofacial dystonia and dyskinesias, I'm not sure whether that projects at all. It does not.
Can you have dystonia in the stomach?
I've come across that question. Okay, I'll repeat the question. Can you have dystonia in the stomach or in your gastrointestinal system? So dystonia typically is a function of a voluntary muscle, even though you don't voluntarily do these movements. So that for the gut, which has autonomic regulation of its nervous system, right, it is unlikely that you could have dystonia, strictly speaking, in your gut, okay? But you could certainly envision where surrounding muscles get into a dystonic cramp or period, and in that reflects on your gut function. And if we can't get it, I will move on. It's yeah, actually behind the presentation. Perfect. All right, thank you. I'll take it from there. In these videos are not the greatest. I spent some time trying to get video general, obviously not CDKL5 based examples, but just so that you have an impression what dystonia can produce, what orofacial dystonia would be like. And importantly, now you can see that this individual's mouth is dragged to one side, and actually in a minute it may occur to the other side as well. And I won't play the whole video, no worries. Right. And he's trying to speak, answer a question, right, and is not able to fully do that. Let me see, where is my cursor? Okay. I'll actually stop it here for the sake of looking at the other video. Let me just cut and paste it in here. And this will be, if it comes up, an example of cervical dystonia. So what I talked to you about, this is a totally different genetic disorder that goes hand in hand with prominent dystonia. And you can see that this individual's head position is pulled back and tilted to one side, and even if he tries to achieve normal function, he can only do that with a certain degree of resistance. He will automatically fall back to the tilted and retrocollis position. Okay. Okay. So very important for your patient population where, or your children rather I should say, where especially communication is obviously a hindrance to them telling you what is going on. You kind of are always put in a position that you have to, well, not second guess, but need to try to discern it from other conditions that could look dystonia-like. One entity is obviously the spasticity that may increase over time, which causes, can lead to contractures at joints and appear, and then basically hold the extremity over time in unnatural positions that can look dystonia-like. However, the clue there is that this is much more of a fixed process and doesn't improve. It doesn't let up at all. A big worry, at least in Rett syndrome, is that a lot of these dystonic episodes, as I had alluded to, can look like seizures. There are dystonic episodes of forced eye deviation that can look very scary, very seizure-like without really being a seizure. Thank you. I had it very nicely up here. Okay. Limb dystonia, especially when it gets severe and maybe is coupled to a tremor, can look very scary and very focal seizure-like. And then, especially early on, posturing can look like dystonia. Posturing, which is predominantly at a very early age, induced by gastrointestinal reflux, Sandifer syndrome, etc. Yes, absolutely.
Looking at the way that the children plank themselves, unrelated, in my opinion, to gastrointestinal reflux, is that a version of dystonia? When you're trying to pick your child up, for instance,
Yeah, and
stretch it out so much that you can't even bend the legs to sit down.
yeah. There, okay. Know that this is a somewhat academic description of these individual movements, right? So there may be a component of dystonia in there. Dystonia can be reactive to stimuli, right? Which you're describing, right? You're basically manipulating your child, and certainly they can become dystonic in the process, but it is not the pure dystonia that I'm describing here that, in a sense, is independent from manipulation. Okay? Does that answer your question? Yep. Oh, I couldn't hear the last part. If I understand correctly what you mean by planking, which is, I can just visualize what you mean. It would be in part a reaction to your manipulation, right? And indeed, yes, and there are certainly disorders, genetic disorders that almost purely go hand in hand with dystonia, where dystonia is the absolute predominant problem, where you work on treatment by subduing your intervention with a child. I'm not saying you should do that in CDKL5 at all. I'm just answering your questions, okay? So there are conditions where these, the planking, right, becomes very, very severe when you interact with a child. And part of the therapeutic approach then is to be very mindful of your interaction with a child. Okay? How do you typically treat dystonia, focal or generalized dystonia? You really have to, as I said in the beginning of my talk, take multiple approaches. And unfortunately, as some of you may have experienced already, treatment for most forms of dystonia is really symptomatic, incomplete, and sometimes if medication use is accompanied by really intolerable side effects. So it is somewhat of a chase of similar, maybe akin to seizure treatment, where you try an intervention, you may reach a point where side effects are intolerable and you have to shift and get going again. The approach of treatment to dystonia in general is largely the same regardless of etiology.
Can I ask you a question? Sorry.
Yeah.
If the dystonia, because you said in extreme cases it could cause pain.
Yeah.
If it's not an extreme case, so it's kind of common on an everyday basis,
Yeah.
so we don't think it's causing pain, what would be the reason to treat it? I mean, what harm would it do? Because obviously the last thing we want to do is bring on more medications and more side effects for our children.
Yeah.
So why would we treat it?
If it is not interfering with your, with the child's quality of life, with the function that, then I would actually not necessarily push to treat it. You're completely correct. If they are brief intercurrent episodes of dystonia, they may not be bothersome enough to actually warrant medication. So you're completely right. There is, and this is something that you'll have to work out with your, healthcare provider. What is the, what is the cutoff where you really feel your child is in distress and needs treatment? There is no hard and fast rule.
And is it common for some of these, the way you're describing, I see a lot of these kind of things in our son. Is it common for them to occur while having a seizure?
Or to bring on a seizure?
No, I would say no. The relationship between dystonia and seizures is very slim, if at all, that there is a relationship. There is certainly, there are possibilities where seizures can occur reflexively to a movement. That's not the normal case. We don't usually put dystonia and seizure, we don't marry them together usually. Okay. They can probably, in rare cases, trigger a seizure. And then vice versa, as I said, if the seizure, for instance, really moves your child, it could be that dystonia is following a seizure, but I wouldn't, that will be very rarely the case. Okay. Okay. So what are some medications, and I'll only skim the medications because those are definitely, you need to discuss what medications are best indicated in your individual situation with your healthcare provider. What I really, by showing you two tables, is to point out that there are several medications. There's not only one, so you have luckily an armamentarium of medications that you can use, and that these medications also belong to different groups, which is always a good thing because you, as I said in the beginning, you try to address the problem of dystonia from multiple angles and maybe from multiple mechanistic angles from medication. So which medications are really commonly used? Artane is one. It's an anticholinergic. It is maybe sort of like a first-line therapy for dystonia. It has the potential for really severe gastrointestinal side effects, for instance, drying, not only a dry mouth, leading to then downstream motility issues, and very often when it is up-titrated leads to side effects in these disorders that make it intolerable. Baclofen is another medication. Clonazepam is one. There have been studies out there where these medications may also have some effect on pain management with dystonia if the dystonia is really severe. And in really almost continuously ongoing dystonia, some heavyweights such as tetrabenazine have been used, and I just wanted to throw out a couple of commonly used names for you. So which other movement disorders do we have? I talked about spasticity, which is really not so much a movement disorder at all, but it sometimes can mimic dystonia. It's a state of increased tone of a muscle that is persistent, and it comes about via loss of inhibition of the motor neurons and is really a stable state. But it can look an awful lot like dystonia. For instance, spasticity of the legs, spastic paraplegia as it is called, leads to an increase in tone of the leg muscles. The thing that distinguishes those two is that in spasticity you have increased reflexes, which you do not have in dystonia. So on exam you can readily distinguish those two. What about two more movement disorders that we do not yet know whether they occur? Well, probably they occur, but to what frequency they do occur in CDKL5 syndrome. One entity that is common in FOXG1, in the FOXG1 disorder, is chorea. And chorea really describes irregular, unsustained movements. So the limbs or the face or whatever is not parked in a certain position or maintained in a certain position, but chorea describes ongoing irregular movements that characteristically are supposed to sort of migrate, flow from one body part that is involved. I will try to mimic it a little bit. I'm not great at doing that, but in an academic sense, it would flow from, let's say, my right arm to the left arm and then to the right leg. There's always a preponderance in one part of the body. And maybe something that we do actually see but haven't recognized that much is a form of chorea, or on the spectrum of chorea, which is called athetosis, which is a very slow writhing, and which I believe I've seen in the upper extremity. So it's really slow writhing movements. It is important to realize that these movements are not patterned, they flow, and they're also not painful. I will try very quickly. There are not really any very good examples of that out there that I could find, but just so that you probably all have heard about chorea Huntington, so a genetic condition that leads to chorea. It's sort of the picture book condition of chorea, and where so chorea, you can see it in this man with chorea Huntington. You can observe that first his right arm will have these writhing, almost dance-like movements, and then when I play the video, they seem to become more preponderant on the left. So now you can see it on the left a little bit more accentuated. That is typically, picture book what chorea would look like. It certainly does not lead to positions that the individual is stuck in. It's all involuntary. Thank you for adding that. Yeah. Mm-hmm. Okay. Let me see whether this works. Could you help me again? Thank you very much. Wonderful. Oh no. How did you flip that around?
I don't know.
Okay.
If you do Command F1, it'll...
Command F1.
Yeah.
Okay, wonderful. All right, so that is chorea. And then another movement disorder that is tricky is the myoclonus, right? And in a majority of cases, myoclonus is really muscle myoclonus. And what it looks like, myoclonus is a very sudden and brief little shock-like jerk of a muscle or of a region of muscles. It's a brief contraction of muscles, or actually the absence of contraction of the antagonist muscles that suddenly, give up counteracting, because all our movements are maintained by a group of agonists and then the enemies, the antagonists, right? And if any one of them lets up, you get you might get myoclonus. It's important, really important, I think, for CDKL5 and Rett syndrome and so on, to know that, again, myoclonus can come about for a huge variety of reasons. Certainly not all myoclonic activity is seizures. There is myoclonic epilepsy, obviously, but it can be physiologic, just the state of the muscle. It can be because of metabolic derangements. Not so pertinent to us. It can come about because of focal damage of brain regions, cortical or lower down. And in most cases, you may, again, akin to the mild dystonia, you might not need to treat all myoclonic activity at all. Medications that is typically used for that are the benzodiazepines. If it gets really, really bothersome in a region, one can try focal Botox injections. All right. So moving on from these baseline movement disorders that may be found in CDKL5 syndrome. Let's move on to more complex movement disorders. We already talked about motor stereotypies, with hand washing being characteristic of Rett syndrome, and interestingly enough, in CDKL5 there are, in over 90% of the individuals you will find stereotypies, but they look a little bit different. So you could potentially tell a girl with CDKL5 apart from a girl with atypical Rett syndrome based on that. It'll never happen only based on the stereotypies, but they are a little bit different. And it may be that we'll learn eventually what that means. The onset, again, most stereotypies occur in the first year of life. Is that at all tied to some characteristic period of brain development? We do not yet know. Even in Rett syndrome, the majority co-occurs with the famous regression in Rett syndrome, but it can occur before and after. It's very important to know that motor stereotypies are maybe the most common movement disorder. In the neurotypical population, in about 20% of children in general exhibit during some time in their lives stereotypies. They will do some tapping, hair twisting, nail biting, midline hand movements even. In one study they found that body rocking behavior when sitting down or head banging occurred in up to 25% of the general population without a diagnosed disorder. And they typically, in the general population, also occur very early on, before 3 years, 80% actually before 2 years of age. And they typically occur in situations where the individual, you could almost say in any situation, but they're accentuated if the individual is engrossed in some sort of focusing on an activity, is excited about it, or the opposite, is really bored or fatigued and doesn't know what to do with her or himself. They typically last, they're not continuous, they're much more in the general population. And even though we do not think that they're harmful at all, they may eventually become self-injurious, socially offensive, or disruptive to tasks that the individual tries to do. Certainly, I see countless cases in Rett syndrome where the repetitive hand-wringing leads to callus formation on, skin abrasions and callus formation on the hands and wrist, where you then have to counteract these motor stereotypies. The stereotypies in and of itself, in themselves, do not appear to be harmful. Yes?
What about biting? Not as an aggressive expression, but just kind of biting around skin.
Yeah, that may, that is on the borderline between potentially being stereotypical and or sensory stimulation behavior. Okay. So really the fundamental characteristic to term something a stereotypy is that they need to occur involuntarily, rhythmic, patterned, and repetitive, almost like a machine-like motion. You could, in extremo, think that a machine would do this repetitive. And they are continuous in contrast to tics or mannerisms. So this table don't even look at the details of it, just exemplifies that it is probably very worthwhile to look at motor stereotypies in CDKL5 syndrome. This person, Temudo et al., these people looked at stereotypies in Rett syndrome, and it behooves us to do the same in CDKL5 syndrome. Because they were able to dissect out much more commonly occurring ones, and then you can target your therapies towards those. Here are just some examples of Rett girls doing these various stereotypies, the hand-wringing, hand-mouthing, retrocollis is on the spectrum of stereotypical behavior versus dystonia. So they're on on the on a spectrum there. How do you really treat them? The question comes up again and again. They're very frustrating to treat. You really can't make them go away. At least in my experience, what you try to do with motor stereotypies is that you try to treat downstream detrimental effects such as skin abrasions, callus formation. If hand mouthing is very frequent, it can have effects on dental health, on the severity of drooling, which can then become a problem for aspiration in some cases. But the underlying stereotypies are very, very difficult to treat. There are some medicines out there that aim at treating them, but just know that they again have potentially severe side effects. They can produce other movement disorders, such as persistent dyskinesias, which you are then really stuck with for a very, very long time. I think what has been used most frequently in the beginning stages may be the benzodiazepine, clonazepam, to try to make the stereotypies a little bit milder. You will not be able to abolish them. And then there are remaining to sort of more complex motor planning for those individuals that can gesture, that can really interact with you in a purposeful manner. There are further movement problems that can hinder those, and those are really ataxia and dyspraxia. So ataxia, that term describes a lack of muscle control and coordination during a voluntary movement and leads to an abnormal trajectory of the movement. It is often noted very, very early on in Rett syndrome, and if the child is functional to the degree that she or he can walk and plan their walking, you will notice that their walk is becoming unsteady, broad-based. There is a fear of falling may develop because of this ataxia. Okay. There are no great treatments. There are some therapy-based treatments to improve the fluidity and the targetness of a movement. For instance, in occupational therapy, music therapy can sometimes improve manual sequences. And for walking, guidance strategies may help out with that, but you can't correct the underlying ataxia in these disorders. Dyspraxia is very often used hand in hand, as it were, with ataxia. It describes a little bit more a cognitive component where the ability to plan and execute a movement sequence is interrupted, and it affects walking and reaching. And you can see that there is a dyspraxic component when executing some movement becomes really difficult for the person to even initiate, meaning to start. And you can see that, for instance, in the fact that their preparatory activity before the individual tries to cognitively reach out to something or start to walk. There may be some rocking behavior, there may be a little bit of shuffling with walking. So you can see that it takes more, as it were, more cognition to do these activities than you would expect. And lastly, for movement disorders, I very quickly want to talk about gait because I think it has a very crucial position in CDKL5 and Rett syndrome. There are characteristics to the Rett gait, right? It is broad-based, tiptoeing. There's a tendency to fall backwards or throw themselves backwards. The initiation of gait is very difficult for them. But we don't know any of that yet in CDKL5. And I think it behooves us, though, to look into that in the future, because, as I mentioned before, there seems to be a real dichotomy. In Rett, when you looked at ambulation, you could really see a parallel to the overall severity of the disease state with the severity of the gait being affected. And even initial reports report that in CDKL5 syndrome, gait co-varies with other symptoms significantly. So I think there may be something there where gait is sort of a marker of severity, but maybe also has underlying biological mechanisms that, if we uncover them, will lead us to an insight in the overall severity of the disorder. So very importantly, third part, I won't go into super great detail. You've heard talks yesterday by Anne Stratton about physical therapy, occupational therapy, other therapies. I mentioned some medications. I think what is very, very important to realize is that if you are concerned about movement disorders in your child, you need to talk to a whole team of specialists, and it should be a multidisciplinary team. Preferably, obviously, a neurologist with some experience in movement disorders. No, I'm just kidding. A physical medicine specialist, physical medicine doctor to address all the more permanent muscular disorders, and venture into treatment such as Botox, bracing, etc. Then PT and OT, I can't emphasize how important that is. Good physical and occupational therapy geared towards your child. And for some very permanent disorders such as severe scoliosis, you may even have to involve an orthopedic surgeon. What will these individuals do? Well, from the neurology side, obviously there is always a big concern. Is this a movement disorder? Is it something else? Is it potentially a seizure? So I think you will experience that many of your children will need an EEG to rule out, possibly even a video EEG to rule out that these movements are not seizures, because there's simply no other way to make the distinction. It's not because that specific neurologist isn't observant enough. There is no other way to discern it from seizures. Initially, there may be the need for an MRI to determine that there is not some other, but CDKL5 individuals can have other brain damage like the general population can have, so an MRI may be indicated. In extreme cases, you may do something similar to a brainwave study. You may do a study on the muscles themselves to record how they are contracting during those movements. And a very first step would certainly be at this day and age to try to record with your cell phones a video of these movements and bring them to the office. And there I can't emphasize enough that yes, the individual movement, let's say it's a focal movement in one arm or one leg. I don't want to do two legs right now. That is very, very, very important, but almost equally important is to go back, zoom out, and get the whole person, because especially distinction to seizures, etc., cannot be made unless you have the full picture of the individual as well. So if you can try, it's obviously a hectic situation, but if you can try to get both the actual movement but then also the whole person. in terms of physical medicine intervention, there's bracing, casting, ankle-foot orthoses. There are botulinum toxin injections, for instance, for the more sustained cervical dystonia, for facial contractures that are persistent, but also for ankle dystonia, which is very frequent, I believe. And if these get fixed deformities, then you have to go towards surgery. A newer entity that is out there for dystonia, at least, is deep brain stimulation, but by no means is it a cure, or better or worse in that sense from medication. It may be indicated in cases where you've tried every medication under the sun, the side effects are impossible. It may be an avenue to attempt to alleviate dystonia for a while. This is just an overview. I don't know how useful it is to you guys of an AFO device to keep the ankles really functional. It's a brace that helps to hold the foot flat, that tends to go pointed over time. But all of these mechanical items have to be used really realistically in conjunction with therapies, OT and PT. Maybe lastly, there is somewhat, let's say in the Rett field at large, there has been in the past a somewhat bleak attitude towards all of these problems, because there is inherently a need for repeat interventions, even surgical interventions over time. And even despite these interventions, there may be a global decline of the physical state. But I'll just throw something out. We don't have that data, unfortunately, for CDKL5 yet. Right, but in Rett syndrome, there have been several studies that show that if you don't let up, if you're very, very vigorous, you stimulate your child to keep walking even when the child is at a stage where it is giving up, so to say, walking. There are individuals like these four girls that lost independent walking and then regained this ability with therapy. And especially in Rett syndrome, this is a huge deal because Rett syndrome comes hand in hand with this very characteristic, devastating regression, right? And walking in general, that is kind of my beef, is very, very important to keep up a functional physical system, because it leads to physiological and psychological benefits for sure and prevents deformities. There is one study where a woman who had been confined to a wheelchair for several years was retrained to stand at age 36. Okay, so that is, and then walking and transitioning from floor to chair by age 40, right? They did a very specific physical therapy there out of Norway. They had, the luxury to observe the individual in the natural environment, clue her into where she was walking before and saying, try it again. You did in the past, try it again. It's by no means the norm, but the possibility is out there. And one study has clearly demonstrated that if you try to keep your child mobile, that general fitness improves. Okay, and then I will finish up that there are multiple ways to study movement disorders. Obviously, for us as a community, it behooves us to do a large we have a lot of work ahead to really characterize movements in CDKL5 syndrome. Research methods used are typically questionnaires that then go into a database, and there are various databases out there. There are video assessments, there are activity trackers that can be used as part of research studies to capture movements. And then a little bit of advertisement. I do study gait in Rett and Rett-like disorders in a professional gait lab at Baylor. And we recently published our first study where we showed that if we got Rett girls to walk on the treadmill, that their gait actually improved, their swing time decreased, their double support time increased, their variability of gait actually decreased. And so we will go further down that path and see whether we can come up with a protocol to study that as an intervention. And with that, I would like to thank you all. I've gone over a little bit, but we started a little bit late. Thank you, obviously, to you all the families without whom we wouldn't be here, right? And letting us interact with your children and try to help them. My mentors, the Bluebird Circle that supports us at Texas Children's, and obviously the International Foundation for CDKL5 Research. Thank you. Okay. Any questions left, or yes?
My son does a lot of extreme.
Yeah.
It's okay. Yeah, sorry. No. He shakes. You know what I mean? It's almost like a muscle spasm. Is that what it is?